Welcome to the deep dive. Today we're focusing entirely on, well, the evidence-based core of clinical practice. We're going to try and cut through just the sheer volume of diagnostic tests out there in musculoskeletal care, and we're asking one single critical question. Which tests actually matter?
Right. And for this, we've pulled from a pretty comprehensive stack of material. It's all rooted in that foundational work associated with Dr. Netter, but it's also been refined by, contemporary researchers and clinicians, people like Dr. Joshua Cleland and Dr. Shane Koppenhaver.
Okay.
Our mission today is simple. We want to give you, whether you're a clinical student or a seasoned practitioner, a kind of shortcut to maximum diagnostic utility.
So moving past just memorizing how to do a test.
Exactly. We're focusing squarely on its statistical punch. What does the result actually mean?
I think it's the biggest realization for any new clinician, right? That no single physical exam test can give you absolute certainty.
Never. Clinical tests are not yes or no confirmation tools. They're tools designed to shift your initial probability estimate. That's all they do.
And to measure that shift, you have to compare it against something, the gold standard.
The reference standard, yeah. That's the criterion we consider the closest thing to the truth, whether it's surgery, an MRI, maybe electrodiagnostic testing. That's our benchmark.
Okay, so let's get into the building blocks then. The fundamental metrics everyone learns first are sensitivity and specificity. We have to have these down cold.
Absolutely. Let's start with sensitivity. It's also called the true positive rate. It's simply the test's ability to correctly identify the patients who truly have the disorder.
So if a test is highly sensitive, it's not going to miss many true cases.
It's very unlikely to. And that leads directly to that classic mnemonic every clinician needs to know.
SAN note.
SAN note. High sensitivity and a negative result are great for ruling out the disorder.
So you get a negative on a test, it's super sensitive.
You can be pretty confident that your patient doesn't have the condition.
Okay. And the other side of that coin is specificity.
The true negative rate. This is the test's ability to correctly identify patients who truly do not have the disorder. A highly specific test avoids false positives.
Which brings us to its mnemonic, SPPIN. High specificity and a positive result are good for ruling in the disorder.
Exactly. A positive result on a highly specific test gives you strong evidence that the pathology is actually there.
Now, sensitivity and specificity are foundational, like you said, but you're going to tell me we need to move past them pretty quickly.
We do. We need to transition to the metrics that really drive clinical decision-making, and those are likelihood ratios, or LRs.
Why the jump? Why aren't things like positive and negative predictive values, PPVs and NPVs, good enough?
Because they're incredibly unstable.
Unstable how?
They are completely at the mercy of the prevalence of the condition in the specific population you're testing.
Okay, unpack that.
Imagine a test for, a rare shoulder issue. In a special clinic where, say, 70% of patients have it, that test's PPV might look amazing.
Right, high prevalence.
But take that exact same test and use it in a general primary care setting where maybe only 2% of patients have it. The PPV will absolutely plummet.
So the test's usefulness changes dramatically just based on where I'm working.
Precisely. LRs fix this. They combine sensitivity and specificity into a ratio that's, it's pretty stable no matter the prevalence. They tell us the magnitude of the shift in probability, which is what you actually need to make a decision.
Okay, so this is where we get to quantify the shift. The positive likelihood ratio, or LR plus L, tells you how much the odds of having the disorder go up after a positive test.
And the formula for that is sensitivity divided by 1 minus specificity. If that number is greater than 1, it pushes the probability up.
And the negative likelihood ratio, LR, does the opposite.
Right, it tells you how much the odds decrease given a negative test. The formula there is 1 minus sensitivity divided by specificity. And LR less than 1 decreases the probability.
But the number itself isn't the whole story. It's the size of the number.
The magnitude.
The magnitude.
The magnitude is everything. An LR of 1.0 is completely useless. It changes nothing. We are hunting for large, conclusive shifts.
And what's the benchmark for large?
Conventionally, an LR plus of 10 or more is a huge shift toward ruling in the disorder. And an LR of 0.1 or less is a huge shift toward ruling it out.
So if I walk into a room thinking there's a 50-50 chance my patient has something, and I do a test with an LR plus of 10.
Your post-test probability just jumped from 50% to over 90%.
Wow. Okay, that's a massive change in certainty.
It is. That's the power of the metric. And there's a tool that helps visualize this called a Fagan's nomogram. We can't show it to you, obviously, but just imagine a ruler. You mark your starting probability, draw a line through the LR you got, and see where you land. High LRs draw a really long, fast line towards certainty.
Okay, that's a great visual. So now that we have this statistical lens, let's start applying it. Let's head straight to the cervical spine. The literature seems to really emphasize using clusters of tests here.
It does. Single tests are often pretty weak, so if we're looking at something like cervical radiculopathy symptoms radiating into the arm, a couple of historical points are mentioned in the sources.
Like what?
Things like symptoms being most bothersome in the scapular area or improving when the patient moves their neck. But here's the catch for you as a student.
They're not actually that useful.
Not for ruling out no. Their LR values are actually over 2.0, which is confusing because an LR over 1 slightly increases the probability. So while they're in the literature, they're really low utility findings.
That is such a critical distinction. We're hunting for those big hitters, the LR greater than 10 or less than 0.1. And the C-spine delivers that, but in a group.
It absolutely does. The research points to a very specific cluster that has, almost astronomical diagnostic power for radiculopathy.
Let's hear it.
It's 4 things. You need a positive Sperling's A test, a positive upper limb tension test A, a positive distraction test, and the patient has to have limited rotation, specifically 60 degrees or less, toward the painful side.
So you need all 4 of those to be present. And if they are, what's the number?
The number is LR plus 30.3.
At 30.3, that's definitive.
It's about as close as you get in a physical exam. If your pre-test probability was only moderate, say 20%, that LR of 30.3 instantly shoots your post-test probability up to 87%. You've gone from my hypothesis to near certainty.
And it's not just about diagnosis. The sources also give us some strong rules for predicting who will respond to certain treatments. What about using thoracic spine manipulation for a neck problem?
Yeah, this is a good one. For patients with pretty acute neck pain less than 30 days, thoracic manipulation shows a good probability of rapid improvement. The LR plus is 6.4.
Okay, 6.4 is good. It's a moderate shift.
It is, but that number can jump way up to an LR plus of 12 if you can identify a specific subgroup of patients. You need 4 out of 6 factors to be present.
And what are those 6 factors?
Okay, so they are no symptoms distal to the shoulder, low fear avoidance behavior, good cervical extension, so 30 degrees or more. They don't have a sedentary job for more than 5 hours a day. They don't need a collar. And finally, their symptoms don't get worse with neck extension.
Find that patient, and your intervention is much more likely to be a home run.
That's the goal, maximum efficiency.
All right, let's shift south. Applying this same statistical lens to the lumbar spine and pelvis. Here, it seems like the patient's history can give you the biggest clues.
It really can. For identifying lumbar stenosis, what's the single most powerful question you can ask?
I'm guessing it's about what makes it better.
Exactly. You ask, are you pain-free when you're sitting down? If the answer is yes, that one subjective report alone has an impressive LR plus of 6.6.
An LR plus of 6.6 from just one question feels almost too easy. Why is it so powerful?
Because it's tied directly to the pathophysiology. Stenosis is a narrowing of the canal. When you sit, your spine flexes a little, which opens up that space and relieves the pressure on the nerves. So if they get that relief, it's a huge piece of confirmatory evidence.
And for identifying a painful lumbar disc, we have the centralization phenomenon.
Yes. Centralization is just when symptoms move from out in the periphery, say down the leg, back toward the center of the spine. It's a highly reliable and incredibly useful sign for discogenic pain. It carries an LR plus of 6.9.
And it's more than just diagnostic, right?
Oh, yeah. It's a powerful prognostic tool. It usually tells you the patient is going to respond favorably to mechanical treatment.
And just like with the neck, there's a clear predictive rule for who is likely to benefit from a lumbosacral manipulation.
We're again looking for a very specific subgroup. The factors are symptoms for 16 days or less, no symptoms distal to the knee, some signs of lumbar hypomobility.
Stiffness.
Right. Low fear avoidance behavior. And finally, limited hip internal rotation, specifically 35 degrees or less on at least one side.
You mentioned low fear avoidance behavior again. For anyone who doesn't use these psychological metrics every day, what score are we talking about?
We're looking for a low score on the fear avoidance behavior questionnaire, the work subscale, or FABQW. The cutoff is a score of 19 or less. That tells you the patient isn't overly fearful of movement, which is, well, it's critical for success with manipulation.
Makes sense. Let's move out to the extremities now, focusing on trauma. This is where you need to make fast decisions, especially about ruling out fractures.
And the Ottawa ankle roll is the global gold standard here. Its sensitivity is just phenomenal, somewhere between 0.97 and 0.99.
Which means its LR is going to be tiny.
It is. The LR is only about 0.10.
So applying SEN out here, an LR of 0.10 tells us what?
It tells you this is an incredibly powerful rule-out tool. If your patient can take 4 steps and they don't have tenderness in those very specific bony zones, you can confidently rule out a fracture and save them from an unnecessary x-ray.
That's huge. Avoiding radiation, saving time, saving money.
It's critical for efficient care.
Okay, let's pivot from ruling out to ruling in. Specifically a tricky one. Scaphoid fractures in the wrist.
Yes, these are so easy to miss. But this is an area where the physical exam just shines. It delivers numbers that honestly rival advanced imaging.
What are the signs?
The source has highlighted 3 that are tremendously diagnostic. Tenderness in the anatomical snuff box.
Classic.
Pain when they try to supinate against your resistance, and pain with longitudinal compression right down the thumb.
And the LRs for those individual tests?
They're almost unbelievable. Each of those signs, on its own, carries an LR plus of approximately 50.0.
50.
50. And an LR near 0, so about 0.00. An LR plus of 50 is just massive. If your patient fell on an outstretched hand and has one of these signs, you have near absolute certainty of a scaphoid fracture. You have to immobilize them and get imaging, period.
That kind of power, an LR of 50, is the perfect example of how knowing these metrics completely changes your practice. Let's finish up with a quick look at the elbow and wrist.
For the elbow, after trauma, the elbow extension test is your rule-out star. Can the patient fully extend their elbow? That's it. It's got high sensitivity, so it yields an LR between 0.04 and 0.13.
So again, if they can fully extend it, you're very likely in the clear for a fracture or a major joint injury.
You are.
And for something like carpal tunnel syndrome, which can be tricky, there's another powerful cluster, isn't there?
Yes, another 5-variable rule. And if the cluster is positive, it gives you an LR plus of 18.3.
Okay, what are the 5 variables?
It's a hand severity scale score of 1.9 or more, a wrist ratio index of 0.67 or more, the patient telling you they shake their hand for relief, diminished sensation on their thumb pad, and being older than 45. Put those together, and you've got overwhelming evidence for carpal tunnel.
So if we synthesize all of this, from the cervical spine cluster to the Ottawa rules, what really stands out is how a smart combination of history and, well, pretty low-tech clinical signs can yield diagnostic certainty that can rival or at least guide the use of high-tech imaging.
That is the ultimate takeaway. That's it. For anyone learning or practicing in this field, we have literally thousands of special tests. The evidence demands we pick the few high-utility ones based on these metrics.
It transforms your thinking.
It completely transforms it. You move from just doing tests to systematically calculating diagnostic probability. You move from guessing to informed action.
So what does this all mean for you listening? It means you have to embrace this evidence-based approach. You're not just performing a list of tests anymore. You are systematically calculating certainty with every patient.
Yeah. And let's try to reinforce that one more time with a final exercise. We want you to work through the mechanics yourself. So imagine a new clinical test for an orthopedic disorder gets published. It has a sensitivity of 0.95 and a specificity of 0.87.
Your job is to calculate the negative likelihood ratio, LR, and then explain what it means using the SN out principle.
Remember that formula. LR is 1 minus sensitivity divided by specificity.
So we take 1 minus 0.95.
Which is 0.05.
And divide that by the specificity, which is 0.87.
And if you do that math, you get an LR of about 0.057.
So what does that number mean?
Well, because that value, 0.057, is so close to 0, it represents a large conclusive shift toward ruling out the disorder. So applying the send-out principle, a negative result on this highly sensitive test lets you confidently exclude the presence of that disorder.
And that is the definition of clinical utility.